Hello, everybody, and welcome to the podcast titled Expert Voices Navigating Non-Muscle Invasive Bladder Cancer. I'm Ashish Kamat, urologic oncologist in Houston, and it's a pleasure to welcome to today's episode, which is Stratification and Prediction in Non-Muscle Invasive Bladder Cancer, Personalizing Care for Patients with Smarter Risk Assessment. Dr. Félix Guerrero-Ramos, who is an expert, really needs no introduction, joining us from Spain, and it's a pleasure to have you, Félix.
Hello, everybody. Hello, Ashish. Thank you very much for the invitation. The pleasure is mine to be here.
So, Félix, one of the things that patients and doctors often face is how do we approach risk stratification for non-muscle invasive bladder cancer? So tell us how you do it in your clinical practice.
Well, first of all, we should highlight that, as stated by the EU guidelines, for example, risk stratification is a must in non-muscle invasive bladder cancer patients because it will guide our treatment decisions and also it will guide our follow-up schedule. In our clinic, we usually tend to use the EAU 2019 guidelines, the previous version, but sometimes we also use the new version of these guidelines, the EAU 21 and later years, which have also a website and an app for telephones. And what we do is we assess with different clinical and pathological features the risk of these patients in order to put them in different boxes to try to tailor the therapy the most accurately to these patients.
So, it's great that you actually publicly stated that you tend to use the 2019 recommendations, because honestly, that is something that I use as well. It's much more clear. It's easy for patients to understand. And it is similar to the IBCG risk stratification, right? And for those in the audience that might not be quite familiar with it, could you tell us exactly what that risk classification is, the 2019 EAU classification?
Yeah, this is a very simple one. One of the main characteristics of this classification is that it's an expert consensus. It's not based on individual patient data like ERTC, Cueto, or EAU 2021, but it's very simple because we have that any high grade, any T1, any CIS are high risk patients, or even those TA low grade, which are multiple, recurrent, and bigger than 3 centimeters. Those low grade patients would be those patients with a primary TA low grade, small tumor less than 3 centimeters, which is a single tumor, and there's no CIS, and all the rest of the patients will be intermediate risk tumors. For me, this is one of the main drawbacks of the classification, that the intermediate risk is kind of a mess of an exclusion criteria, where any patient which does not fall either in the higher risk or in the low risk category will fall into the intermediate risk. But as you know, we will have some other tools like the IBCG subclassification of intermediate risk according to different risk factors.
Yeah, and just for the listening audience, there's a separate episode that we did on the intermediate risk patients where we went into a lot of detail with the IBCG risk classification. So I encourage those to listen to that podcast. So Félix, when you're sitting and talking to a patient, sometimes patients come and they don't really want to hear the details of the risk classification, but they still want to know why you're recommending a certain treatment to them based on their risk of recurrence and progression. So can you guide us and tell the audience how you go about that with your patients? How do you discuss this with them?
Well, when a patient has a non-muscle invasive bladder cancer, the first thing we say is that they don't have currently at the moment a life-threatening disease, but we have to look at the risk of progression. And I explain to my patient that the risk of progression means that the tumor can go into the muscle layer, and that implies that 50% of the patients then will die from their disease, no matter what we do. With that in mind, I explain to my patients that according to the risk of having that more advanced disease and more dangerous disease, we look at certain clinical and pathological features, and that's why, depending on that risk, we decide either one treatment or a different therapy.
Great. And I think patients really appreciate to hear that, right? So now, when we're looking at the different risk categories, the low, intermediate, and high risk, how do you, or what treatments do you offer, for example, for patients with low risk disease, intermediate and high risk? Just briefly, between the low and the high risk patients.
Yeah, it's very easy, and it's according to the clinical guidelines. So the guidelines recommend for low risk patients, we usually do not recommend any adjuvant therapy, just follow up. For low and intermediate risk patients, we try to use, if it's feasible and there's no complications, a postoperative installation of chemotherapy in the first 24 hours after the TURBT. For high-risk patients, we are recommending BCG 1 to 3 years. We don't recommend BCG 3 years to every patient. We can speak on that later. For intermediate risk patients, we tend to use the IBCG subclassification to decide whether to go to either observation or BCG or even chemotherapy, standard chemotherapy, hyperthermic chemotherapy, or any other options.
You know, that's wonderful. That's very clear. And now let's get into something that's a little bit more muddy, right? So when you're recommending immunotherapy with BCG for patients that are high risk, clearly that is something that is standard of care and has the longest track record. But within that high risk category, you have patients that have very high risk features, you know, some that have multifocal CIS, some that have T1 high grade disease. How do you decide which patients you are going to offer BCG to? How do you essentially track these models and then make your decision in who you're going to recommend cystectomy, who you're going to recommend BCG, et cetera?
Well, in general, for those patients with very high risk disease, of course, we explain the very high risk of progression to muscle invasive bladder cancer, which is a life-threatening disease, as I said before. And for these patients, we usually tell them that radical cystectomy is the safest oncological therapy, and that's true. But as we know, and there's evidence on that, it can be an overtreatment in certain patients. So in spite of advising them about radical cystectomy, there are some of these patients where we offer that BCG could be a reasonable first-line therapy and see how it works. Not all the very high-risk patients are the same. Of course, if we have patients with neuroendocrine or different histological subtypes, we might we might tell the patient more about radical cystectomy. But for example, if you have a patient with a T1 high grade, 3 centimeters plus CIS, who's 72, and this is a very high-risk patient, we can recommend BCG. Always bear in mind that radical cystectomy is the most radical therapy and the most safe therapy, but we can tell these patients that we can do a trial with BCG before going to radical cystectomy, because it does work, and there is some evidence on that, on the performance of BCG in the very high risk group.
Yeah, and if you look at the risk classification system, especially you look at the prognostic tools that the EORTC puts out, it's important again to recognize that 40% risk of progression is in patients not treated with BCG, right? And in today's day and age, at our center, for example, the progression rates are in the single digits for the most part, and I'm sure in your center too, when BCG is done appropriately for the appropriately selected patients, they can do quite well. But Félix, you've done this a long time. I've done this a long time. We always will sometimes meet patients that have extremely high risk disease, in which something is telling you that this patient should really be considered almost like they're muscle invasive. Could you share with our audience what are some of the danger signs or the red flags that make you tell the patient, listen, if you were me, I would take my bladder out?
Yeah, one of the main red flags is lymphovascular invasion, for sure. We know that lymphovascular invasion predicts a much poorer prognosis than those patients who do not present lymphovascular invasion in their tumors. And this is important to ask your pathologist to look for that and to report that, even if it's negative, so that you can state that there is not lymphovascular invasion. If there's a patient with a T1 high-grade tumor with CIS, or even without CIS, T1 high-grade with lymphovascular invasion, for this patient, I will certainly recommend radical cystectomy as an upfront therapy. And then, as I said before, patients with histological subtypes or patients with multiple T1 tumors with CIS or tumors in the prostatic urethra, even if we rule out there's a T4 tumor after looking at the prostatic stroma. For these patients with very high-risk features, I would recommend a radical cystectomy because they're uglier tumors to me.
Yeah, these are great points. Do you use molecular classification or any of the emerging models and et cetera, AI models in your decision making?
No, we don't. Outside clinical trials, we do not do that. We've been looking at some molecular markers, and we're using some microRNA-based things with the Vladimir test, which is a test we patented and we are developing. But all this is within the clinical trial or the research setting. There's no molecular profiling that we do in the current clinical practice.
Yeah, and I think that's another important point because there's a lot of these AI-based tools, there's a lot of these modeling that are very promising, and we're all excited to see where this takes us. But currently, they should be used a little bit with caution, more of a supplement or complement to how you counsel patients rather than an absolute, which is critical because we get patients sometimes that come to us with literature printed from the internet, and they think that they could put in the numbers into ChatGPT or something like that, and it will spit out the recommendation. So that's a little bit of a dangerous thing that we need to educate our patients about. But clearly, there are molecular insights that will influence our treatment decisions right down the road. So, for example, if you have somebody that has BCG unresponsive disease, and we'll talk a little bit about BCG unresponsive, are you then sending these tumors to be profiled, or are you only doing this for clinical trials?
Nope, we're doing this only for clinical trials. Currently, the only clinical trials for which we have targeted therapies are those with intravesical erdafitinib. So these patients who are BCG unresponsive, the only patients with BCG unresponsive disease are those papillary tumors who are BCG unresponsive that are candidates for a clinical trial with erdafitinib, and they undergo FGFR screening mutations or fusions, which is the target of this therapy.
Now, speaking of BCG unresponsive, that's a definition that is very confusing sometimes, not only to the average physician, but also experts and patients, et cetera, right? It's a definition that was proposed to the FDA by expert groups here in the US that I was fortunate to be part of, and along the others, of course, and the FDA adopted it, and it led to an explosion of single-arm studies. Félix, let me ask you to enlighten our audience and explain what exactly is BCG unresponsive definition and how do you use that in your clinical practice?
Well, BCG unresponsive includes those early relapsing and refractory tumors. This means any patient with a high-grade recurrence up to, let's see, there are two groups, those patients with CIS and those patients with papillary-only disease. For patients with CIS, any high-grade recurrence up to 1 year after completing BCG would be a BCG unresponsiveness status. And for those patients with papillary-only disease who experience a high-grade recurrence up to 6 months after ending the BCG therapy would be considered BCG unresponsive. And here I would like to congratulate you because you also sometimes said in certain scenarios and certain meetings that, and it's true, this definition was developed for the development of new drugs and clinical trials. But some months ago, there was a clinical validation of the definition where we see that the definition that you and the other group, all the group of experts developed, is useful in clinical practice, and it also differentiates the prognosis between the different patients who are not responding to BCG. So there was this external validation. This was a very nice paper, and it showed that it can be also applicable to clinical practice.
Yeah, and I think that was critical, right? Because people were automatically using this in clinical practice without actually studying it. And that's a little bit of a cautionary tale that we want to put, that we want to have more drugs approved. We want to have single-arm studies, but we don't want patients to unnecessarily suffer a label if it's not going to help them get the best treatment. Again, let's stick in this sort of arena, right? Patients that are high risk, and now you're considering between BCG and chemotherapy or other treatment options for the naive patient. How do you make that decision?
Well, those patients who are high risk for sure will undergo, well, first of all, it's not only the risk classification, the risk stratification, it's also the patient profile. If I have a 92-year-old lady who is ECOG 3 and has a high-risk tumor, I would probably not administer BCG, and plus I would probably not follow her up with cystoscopies, just ultrasound, or even if you have any hematuria come back. I mean, you have also to tailor the treatment to the patient, not just to the tumor, and that's important. But in general, for high-risk patients, we use 1 year of BCG. We usually keep 3 years of BCG for CIS and for those very high-risk patients who are not undergoing upfront radical cystectomy. For intermediate risk patients, we're trying to tailor the therapy according to the IBCG risk factors. It's true that most patients have at least one risk factor, so not many of these patients will undergo observation. And we usually decide between intravesical normothermic chemo. Some of the patients will undergo hyperthermic chemotherapy, and small proportion of the patients will undergo BCG if they present several risk factors, or especially if they have their tumors have failed to previous intravesical chemotherapy.
And again, is the BCG for 1 year mainly because of the shortages, or is that something that you've transitioned to even if you had plenty of BCG?
Well, in my center, I started coordinating the oncology unit in 2018, 2019, 6-7 years ago, and they had always been doing 1 year, so it was new for them when I started with 3 years for these very high-risk patients. But looking at our data and also at the burden we have in our clinic, and at also the rate of completion of the treatment of the patients, I believe that for most patients with high-risk disease, 1 year is enough. Although we know that 3 years, according to the meta-analysis performed previously, is better. But most of our patients, I think 1 year is enough. So that's why we keep 3 years. We have a lot of patients in our clinic. There's a lot of burden, and we have to keep 3 years for those highest risk patients. But as I said, even without a BCG shortage, we tend to use 1 year BCG with our patients.
Yeah, that's interesting. That's a little bit different from what is on our recommendations in North America and the guidelines, because for high-risk patients, if they're high grade, it's recommended that you consider 3 years of maintenance therapy, and you can decrease it to 1 year if there's a reason, such as TA disease or there's BCG shortage. I think you're saying the same thing, because you use 3 years for CIS and you use 3 years for T1 disease. So automatically you're using 1 year for TA patients, right?
Yeah, that's something like that. Yeah.
Okay, great. Now, Felix, if a patient becomes BCG unresponsive, what's your counseling?
Well, when a patient becomes BCG unresponsive, first of all, we have to advise the patient of the risk of the disease at that moment, and that we know that BCG, which is currently like the best intravesical therapy, will not provide much benefit, and the main recommendation is radical cystectomy. But radical cystectomy is also an over-treatment for some patients. The problem is that we don't know who will benefit from radical cystectomy or from other novel therapies or alternative therapies. So recommendation is to undergo radical cystectomy. However, we offer our patients being enrolled in clinical trials. We are a high-volume center, and we have a lot of clinical trials. And sometimes if the patient is unfit for radical cystectomy or refusing radical cystectomy, and also unfit or refusing clinical trial, we can use any of the different bladder-sparing approaches. In our case, we have available recirculant hyperthermic intravesical chemotherapy, so we offer them HIVEC.
Yeah, and I like what you said, because it's very important to incorporate patients' desires and the quality of life measures. because at the AUA meeting recently it was presented, and it was a little surprising to some to see that some patients actually have a better quality of life when they have their bladder taken out, rather than when they leave the bladder in and undergo multiple rounds of treatments. And some of us, believe that it's partly due to anxiety, right? The risk of having the bladder in place and trying multiple things, not knowing if it's going to work, might make the patient more anxious. Félix, it's always a pleasure to chat with you, and we're coming up on the closing minute or so. So let me ask you at a broad perspective, what is your take-home message to the listening audience on NMIBC risk stratification? Where do you see that risk stratification going in the future, and what would the ideal model look like for you?
Well, first of all, for the audience, risk stratification is a must in non-muscle invasive bladder cancer because it is the best way we have nowadays to tailor the therapies to our patients, either intravesical or systemic therapies. Number two, the future models will probably integrate big artificial intelligence data and also some molecular profiling. But I think this is not close, as we need validation for these molecular classifications, and they are also expensive and not easy to implement in certain smaller or community centers. But for the audience, if you want to tailor the treatment to your NMIBC patients in the best way, you must stratify these patients in the different risk categories.
That's great, Félix. Again, I want to thank the audience for joining us on Expert Voices. I want to thank Dr. Guerrero-Ramos for his expertise, and stay tuned for the next episode.
Thank you very much, Ashish, and thanks to the audience for their attention.